Hello, Dr. Rudick, and thank you very much for being part of this taped interview, part of BioNews Services' official coverage of ECTRIMS 2017. Biogen is running several large-scale projects to gather various types of real-world data that will help to advance the understanding of MS. Three efforts, sensors being used in the search for digital biomarkers, MS pads, and what's called the BMSD, the big data. They will generate huge amounts of data and place specific requirements on its analysis, of course. What approaches or strategies is Biogen using to mine this data?
Yeah, I think that the context for this is that healthcare is moving in several directions in the direction of measuring the outcome of interventions, as opposed to healthcare paying for products and services and procedures. We're making a transition to paying for value in healthcare. So where the real-world data and real-world evidence programs fit in is to a much bigger picture in the transition of healthcare from payment for services and products to payment for outcomes and value. So we're really focused on outcomes. That's point number one. And we're focused on outcomes that matter. That's point number two. And we're focused on generating information where the patients are, which is in the healthcare system. So the context for all three of these projects is the need to move into the future in medicine in the direction of personalized medicine so that we can learn enough to get the best outcome for each patient using the available therapies. And they're not just medicines. There are other forms of therapy too. So the first thing we have done is we've decided that we need to measure the outcomes that may have some relevance to the patient. So for instance, in the MS PADS initiative, in addition to the traditional motor outcomes and relapses, in every patient in that program, we're also measuring 12 dimensions of MS that the patients report. Things like fatigue and depression and social stigma. We're also measuring cognition in every patient in that program. We're up to about 7,500 now. We'll be up to 12,000 probably by the first quarter because of the way we're collecting this data. But we really feel that it's necessary to measure the outcomes that matter to patients. Now, how do we know that these outcomes matter? We're finding that 22% of the patients, the first 5,000 patients in this MS PADS project, have pretty significant depression, measured by the standardized Neuro-QoL depression scale. 22%. And those on the antidepressants, it's even higher. So we're not fixing that problem with antidepressants. We're finding that cognitive impairment is highly correlated with the outcomes we think matter. Employment, living independently, and disability insurance. So we believe strongly that we have to collect a lot of data, but that we have to collect the kinds of data that really make a difference to patients. And we're doing that through this MS PADS project. Now, going beyond that, technology is just expanding like crazy. And we have an explosion of new possibilities. So we're exploring that in the Verily project. So in the Verily project, we put the Verily digital wearable technology on patients and did an in-clinic assessment using 9 sensors per patient to figure out where we needed to put the sensor. And we found out that if we put a sensor on the wrist and a sensor on the ankle and one on the sternum, we could get all the information we needed from all. We didn't need 9 sensors, we could do it with 3. So we had patients go home into their living environment and wear these sensors for 6 weeks. We had 50,000 hours of continuous data from about 25 patients living at home, going about their business. And through the big data informatics, we were able to reduce all of this data and identify signatures that correlated pretty well with the way doctors quantify MS severity. They're novel. They're novel digital biomarker signatures of MS severity that we can get from patients just going about their business.
How many signatures have you collected?
Well, we have reduced it to around 6 or 7 metrics. From all of this data, we found 6 or 7 that are independent predictors of the disease severity. So we're exploring now how we can connect that technology with MS paths, because maybe we could get the information from the free living environment that would help us understand better what matters in
the
MS.
clinical.
So what really matters to people with MS is that they maintain their roles, they maintain their employment, they can think, and they can go about their business. And of course, we believe that the medicines we have help a lot in that regard. But as we go forward, we're going to have to learn how to use the medicines for the individual patient to get the outcome that we're shooting for, which is complete disease remission. And in order to do that, we're going to need a lot of information. I'll give you another example. We believe that coexisting medical conditions may make a difference, and we have not paid much attention to that. So what about the patient who also has diabetes and smoking? They're going to do differently than the patient who doesn't have those coexisting medical conditions. So in the MS Paths initiative, we're able to look at that because we have access to complete EMR data. So for the first time, we're going to be able to look at the intersection between the medications, the individual's characteristics, the behaviors, and the comorbidities. And we're collecting DNA as well. So we'll be able to look at how this all fits together. That's going to be a huge big data project. And it's not just the number of patients, it's what you have to analyze.
Exactly. You talked a little bit, actually, before we began, about the quality of data and the type of data being almost more important than the amount. Though clearly a great amount is coming in. In MS Paths, that is the data being collected in the clinical setting.
Yes.
How does that differ substantially? How did that differ from the data that's being collected at Verily or Brigham and Women's Hospital, which is the wearable sensors? And how are you tying them two together?
Yeah, our plan is to test the new technology in the patients who are participating in the MS Paths project. And that way, we can determine whether a new technology like a wearable device or an app or any new technology adds value to the things we're already collecting traditionally in the office setting. It may be that we could minimize the number of visits. Maybe the patient doesn't have to go in as often. Or we may find signatures using the new technology that we see earlier than we see clinical changes in the office visit. But the patients go to the doctors do an assessment, the doctors try to make the best decision, and we believe that it's really going to be important to bring decision support to the doctor using the data that we're collecting so that the doctor will have assistance in making the decision through deep learning and machine learning and artificial intelligence and decision support. That's where we're going eventually, because the world is becoming so complicated and there are so many factors that are going to influence an individual's response to a particular therapy and the outcome that we believe we're going to need this data to move to the next generation of care.
Are doctors now using the two? Are some doctors being, maybe perhaps those at Brigham and Women's Hospital, are they at all being fed this data from the wearable sensors? Is there any connection at this point?
Not at this point. This is all in the development phase. Mm-hmm. But looking down the road, I'm looking down the road 20 years. Our goal is to put MS into complete remission in every case. And that's going to take an individualized approach based on the individual characteristics of the person, the severity of their condition, their response to particular medications. The key to getting there is the data.
When might patients expect these efforts to begin to pay off? Do you have any idea at this point?
Well, I think it's going to be sooner than people think, because we're collecting the science of informatics is advancing so rapidly. The only thing missing is the data. And we've taken a very interesting approach in MS Paths. Rather than having the physicians and the providers collect the data, take their time collecting data and entering the data into a computer, we've taken the approach of using computer technology, patient engagement, and automation, so that when the patient goes to the clinic, she can do her own assessment using the computer device we've developed, and the doctor doesn't have to take any time. As a matter of fact, the program was designed so that the physician would have more time to spend talking to the patient and need less time collecting data. So we believe that computer technology could play a huge role as we automate the process of standardized quantitative data collection. That's a fundamental strategy that we've taken to allow data to be collected on every single patient.
How long has this been in operation? How long have you been?
It's up and running now. It's been running the first center about a year and a half ago, and all 10 centers are now up and running, 7 in the U.S., 2 in Germany, 1 in Barcelona, in Catalonia, Spain. This data is now all being combined internationally, and it's all highly standardized, quantitative, multidimensional data. It's pretty exciting.
And Biogen will be, for the time being, this is Biogen's data that you will be working at, Biogen will be working with to mine, to develop the personalized approaches, to see the biomarkers, or to look for the biomarkers that are indicative of...
Well, to be really clear about this is a collaboration between Biogen and 10 large institutions.
Right.
And the investigators and clinical partners at those institutions have complete total access to the data. So that data will be analyzed both by Biogen, also by the investigator community, and in many instances as a partnership between the two. That data is available for NIH grants and MS grants. So we're really hoping that the data will be used to the maximum extent. We just have not made a decision to release this publicly yet.
Are you finding specific biomarkers that are really, you've talked briefly sort of with cognitive and kind of problem depression, but are there biomarkers that you're beginning to spot out?
Well, the one we're most interested in right now is the neurofilament test. Mm-hmm. Neurofilament is a protein that leaks out of the nerve cells as they're damaged and die, and we can measure this now in the blood. So we're collecting blood on every patient, and we're hoping that the neurofilament will be a good way to measure the disease severity, to predict how it's going to go, and even measure the treatment response. So we're very interested in neurofilament as probably the first biomarker that will be clinically useful to us. We're also collecting DNA, though, and we want to sequence all of these patients and determine what genetic component there is to disease progression and response to therapy. So those plans are in the works.
Is there anything, just you would like to add, or is there any, point that you...
Well, I think we're moving into the future in healthcare. I think that 20 years from now, hopefully, you'll look back and won't even recognize the way we did it. hopefully through technology, patient engagement, a more holistic look, and a laser focus on outcomes, we're going to be able to get much better outcomes in MS and other neurologic diseases where we're also going to need these technologies. So I think this is really exciting. We have to move into the future.
You think that it really does come down to the future is going to be one of absolute personalized medicine?
Absolutely. Now, neurology is behind oncology and cardiology and diabetes. Why? Because those fields have had treatments for much longer, and they have come to generate standardized data. In diabetes, you have blood sugar, you have hemoglobin A1C, and you have clear-cut outcomes that matter. And we can collect that and learn how to individualize the treatment. When you think about it, we individualize treatment for every diabetic patient. We have a target, and we adjust the insulin to hit the target to get the best outcomes. We're going to go there in neurology, but we're just at the cusp of personalized medicine in neurology. And because we have MS drugs, this is the first treatable disease we've had. This is going to move now. This is going to move into Alzheimer's disease and other chronic progressive neurologic disease. We're going to get to personalized medicine, but we have to measure outcomes that matter, that are quantitative, using technology and automation, and then we have to use that data to learn.
Could a disease as heterogeneous as MS, and I honestly don't know if diabetes we can consider, but MS is certainly a very varied disease based on the patient. Could there be that one target, like in diabetes, that would apply across patients, or is that part of what the whole biomarkers?
Well, I think this is what we're learning. We have to learn what are the targets for our therapy that will relate to outcomes that matter, like employment, independent living, and disability, because we want to treat early. And so we can't wait until we see these outcomes that matter. We have to interrupt them. So identifying the target of treatment, just like in diabetes, we target the hemoglobin A1C. We need to develop those treatment targets in MS, and then we have to learn how to use the drugs to affect those targets in individual patients. We're going to need to bring in a lot of information, the medical history, the genetic information, the behaviors like smoking. And we're going to have to figure out through a process of big data and learning how to individualize that treatment. But we have the therapies, and I think we have the technology. We just have to collect the data.
Thank you very much.
Okay.
I really do appreciate it.